Good afternoon, everyone. I hope you're enjoying the conference. Thank you for joining us for the final session, Universal Screenings as a Tool for Child Well-Being. We are looking forward to a great session. A few logistics notes as we begin. This session is being recorded and the chat is being archived. Attendees are in view-only mode to keep things orderly. You cannot use your microphone. We encourage you to use the chat box throughout the session to engage with the group. You can post in the chat for any technical issues you experience, as well as any questions you would like to share with presenters. We will share these questions toward the end of the session. This session uses auto captioning. While these captions will not be exact, we hope they can improve accessibility for all attendees. To activate these as a viewer, please look for an option on your toolbar that says Live Transcript and select either Subtitles or Full Transcript, which will appear in a sidebar. Your options may differ on a mobile device. A recording of this session will be made available on our YouTube channel. A quick note on professional development credits. If you are an early educator intending to claim professional development credit through South Carolina Endeavors, please complete the submission form we are about to share in the chat box before the end of the session. This is essential to having the information needed to process your credits. Remember that you must attend the session for its full 1-hour duration to receive credit. These sessions are also eligible for CME credits. Further information, including the link to complete your attestation form, will be sent in a follow-up email. For CME and all other professional development credits, ICS will be happy to provide verification of attendance. For that and other professional development inquiries, please contact John Young-Shik Conklin. His email will be in the chat. If you have questions about this process, please return to the Zoom lobby after this session and someone can assist you. We encourage you to use the hashtag NDM2022 when you post on social media. At this time, I am pleased to introduce Loretta Crowley, who will moderate today's session.
Thank you, Lisa. Welcome to everybody. My name is Loretta Crowley. I am the Health Education Manager for the Institute for the Advancement of Community Health at Furman University, and I'm honored to have the opportunity to serve as the moderator for today's panel discussion on universal screening as a tool for child well-being. I'd like to begin our session today by welcoming our esteemed panelists. Kristine Hobbs is the Mental Health Integration and Care Coordinator with the South Carolina Department of Health and Human Services. Kerrie is the CEO of the South Carolina Infant Mental Health Association, and Dr. Sease is the Medical Director for the Prisma Children's Hospital Bradshaw Institute for Community Child Health and Advocacy. And I would really encourage everybody to go, that's just a super brief overview of our esteemed panelists, but I would encourage you to go. There are detailed bibliographies for each of the panelists, and those can be found in the speaker tab in the lobby. I encourage you to take a moment to review the detailed biographies as they highlight our panelists' professional careers and phenomenal contributions to the field. So to begin, the format for this panel discussion is a little bit different than ones that you have may have experienced throughout the day today. The format for our discussion will be a conversational panel in which the panelists will share their professional knowledge and expertise on using universal screening as a tool to promote child well-being. The conversation will be structured with a series of questions that hit on key themes, including how we address the ways in which screening can be used in the context of various settings. We'll highlight the different types of universal screening tools and their application. And then the conversation will help us all appreciate how screening tools can be used to promote well-being. So for a housekeeping item, we do have the chat up. I encourage everybody to use the chat throughout the session to engage with the group. Lisa and I will both monitor the chat and do our best throughout the session to incorporate the questions into the flow of this conversation. And then we've also allocated time at the end of the session to circle back during the audience question and answer. And we'll try to make sure that we incorporate and address all of the questions that you put in the chat. So to kick things off, I am going to begin our panel session by asking the panelists questions, and we'll just rotate around. And like I said in the beginning, the format and the structure that we're going to use for this session will be just a conversation with the panelists so that they can share their expertise and their professional knowledge. So I'm going to start our session off with a question to tell us a little bit about your role and how universal screenings are utilized within your program work. And Kristine, you're at the top of my squares in my Zoom screen, so we'll start there. So tell us a little bit about you and your role and how universal screenings are utilized within your program or work.
I work with the Q-TIP program out of the Department of Health and Human Services, and that is a group of, it's a collaboration between the Department of Health and Human Services, the South Carolina chapter of the American Academy of Pediatrics, and various pediatric practices around the state. And when I started this job in 2011, one of the asks of the pediatricians I work with was to come up with a set of recommended screening tools that they could use in their office. There's just so many tools out there, and it was really difficult to kind of sort through those as one pediatrician and then kind of decide what of all of those tools would be the best tools for them to use. So in 2014, might have been 2013, we came up with a recommended screening protocol for I call them our tiniest, our little tiny people, our elementary school people, and then our budding adults, our younger, preteens on through teenagers as well. And some of the screens or tools that my colleagues might talk about today may not have even been tools at the time that we introduced that screening protocol. So it's left open. It's the clinician's decision based on their population and their staffing and what they feel most comfortable with for the tools that they choose. But it was a really hard ask in the beginning to just kind of start somewhere with recommending a battery of tools. So we had very few practices that were using standardized screening tools in 2011, and the majority of the practices that I work with now are using one or more standardized screening tools at this point.
All right, thank you so much for sharing. Kerry, Schnake, would you like to do the same? And I'll repeat the question because I know it'll be hard to circle back around. So tell us a little bit about your role and how universal screenings are utilized within your program or work.
Right. So I'm the CEO of SCIMHA, which is South Carolina's Infant Mental Health Association. And we really promote and weave developmental screenings into all of our programs, but the initiative most well known, I think, and associated with screening and doing the focus work on promotion of screening and referrals is under the SCIMHA umbrella is Help Me Grow. I think that's probably a program many people in the state are already familiar with. The South Carolina affiliate of Help Me Grow has been in place for many years in the state, originally established under Greenville Health System, which of course is evolved into Prisma Health. And then in 2020, Help Me Grow state office was created at SCIMHA, where the focus has really been on expanding Help Me Grow and the resources available statewide. And so it's kind of an interesting and maybe not at first blush a connection you would make between specifically infant mental health and developmental screening, but it's the national partners like to talk about how the core values of Help Me Grow is so aligned with the core tenets of the mental health field that it's really putting early childhood development at the center. It's appreciating that support for child development is really about strengthening the parent and caregiver's ability to support their child and giving them the information and resources they need, particularly in times of stress. And that both are kind of rooted in this understanding that a young child's relational health, which is the quality of the relationships that a child has with their primary caregiver, that is the foundation on which all other development is built. And so always keeping that in the center when not just working with families to encourage developmental screenings are completed on the children, but then what do you do with that information afterward? So for those who don't know, Help Me Grow system makes developmental screenings universally available, free, accessible, using the Ages and Stages questionnaire and the ASQ social emotional version. There's an online portal where families can go and professionals can go and with families to get developmental screenings completed. But that's only part of the equation. The screenings are only helpful, as we know, if they connect children and families to resources they need. None of us are doing this just to tick the box to say we did a developmental screening. And I think that's one of the features that's really special about Help Me Grow is it is this free access to screenings for families anywhere in South Carolina. And then it's followed up based on those results with a warm handoff from a care coordinator who connects the family with resources and services they might need in their community.
Great, thank you so much. And Dr. Sease, tell us a little bit about your role and how universal screenings are utilized within your program or work.
Sure. So I'm Kerrie Sease. I'm a pediatrician with Prisma Health, and I think it's appropriate that I went last because I am a member of Q-TIP and have been part of the inaugural collaborative, and Help Me Grow was with us here at Prisma Health prior to making the state office within SCIMHA. And so I can probably tie a lot of this together. So we do universal screening in our practice here, and I totally agree with Kristine. It was so overwhelming in the beginning to know when, what screen, which ones are recommended by the AAP, which ones do insurances recognize, et cetera. So the Q-TIP collaborative has been huge. And I just saw it pop up in the chat. Q-TIP stands for Quality Through Innovation. I don't know, Kristine, in pediatrics. Okay, and it is basically a QI or Quality Improvement Collaborative as a joint venture between South Carolina DHHS and our South Carolina chapter of the American Academy of Pediatrics, where we bring pediatric practices across the state to share in a collaborative model around best practices. And initially, a lot of it was around screening, but we have done multiple projects around best practices to bring to our pediatric practices in the state. And so universal screening or developmental screening is one of those. So through my work with that, and then at the Bradshaw Institute now, we have implemented universal screening across all of our child serving practices within Prisma Health, which was a really big undertaking. And I'm really proud to say that we are now doing that. So we use the SWIC, which stands for the Survey of Wellbeing in Young Children, for children ages 2 through 5. It incorporates developmental, behavior, strength-based questioning, and family questions. So we're tiptoeing into that universal social determinant screenings as well in that 2-month to 5-year age. We will be implementing the pediatric symptom checklist for children 6 to 11, which looks at some early mental health and behavior, as well as kind of school readiness issues and school issues in that 6 to 11-year-old. And then in the 12 and over, we do the PHQ, or the Patient Health Questionnaire, which is a depression screening for children 12 and older, as well as we incorporate what's called the HEADS assessment, which is a universal it is a comprehensive adolescent screening tool as part of our adolescent well child check. And we also, on the adult side, I know this is a pediatric conference, but on the adult side, within Prisma Health, we have initiated universal, or are about to initiate universal social determinants of health screening. So in the health system, to do universal screening just means at every well visit. So for children, that's multiple visits, but as you grow and come annually, we are hoping that at every time you enter the system for a well visit, you will have some type of universal screen around your social determinants done when you enter our system.
Great, thank you, Dr. Sease. And as the audience, I think super interesting, we highlighted kind of in the beginning, I think Kristine kicked it off by saying there are a lot of different types of screening tools. And so I think as you've heard our different panelists reference that, that's something we'll kind of circle back around to, that there are different types of screening tools and different settings that they're used in different applications. So as we continue through the conversation, we'll kind of build out on that as we get going. So maybe Dr. Sease, if I could start back with you on this set of questions. We would anticipate anytime you're working with something universal, as the topic for this panel discussion is universal screening as a tool for well-being. And anytime there's something that's universally administered, there's going to be some challenges, and because there's so many factors at play. So I wanted to see if the panelists can tell us a little bit about implementation challenges that happen with screening tools and getting a universal screening project up and running.
Sure. Yeah. So, I mean, in a large health system, I think there's a lot of implementation challenges. We have to think about the workflow within all of our practices. As Kristine alluded to, not everybody was doing universal screening back in 2011 for sure, and even in 2022, not everybody is doing it. And so we initiated this. We got funding through HRSA. It was a joint grant opportunity from the AAP and HRSA that we were able to secure here at Prisma Health that allowed us to really tackle this. We had to have a lot of buy-in from top down. We had to determine which screening tool we were going to use. So again, a lot of work on the front end. So again, we had to have buy-in from our chair, from our medical directors across our system, our developmental peds team. So Dr. Kelly at the time, Dr. Des Kelly was the head of developmental behavioral pediatrics. And so we worked closely with our team there to determine which screening tool was going to be the best one to use. There are multiple ones. No one is better than the other necessarily. But we wanted to say what was a brief tool that we could use in practices, one that our developmental pediatricians were okay with us using, and one that we knew would fit into a workflow. So a lot of pre-work had to happen before we were ready to turn that on. We went from paper screening to electronic screening. We switched electronic health records during the process of this. So there was a lot of issues with that as well. And so, just a lot of processes we had to determine, billing, the list kind of goes on and on. I would say the biggest hurdle we had was really buy-in from the practices. And I don't mean buy-in that this was the right thing to do, but again, workflow. Well, who's going to give the screen? And when it was on paper, how do we get the front office involved? We had to scan them in, just, so many things. Now I can happily say we are doing these electronically. We do what we now call the eSWIC. And so it can be sent out as a pre-visit questionnaire to patients who are on the MyChart portal. We use Epic. If they don't have access to that, we have a way for them to do it electronically when they check in. And then we only have that in English and Spanish. So if somebody prefers to speak a language different than English or Spanish, then we move to the paper copy. So we have layers of opportunities for them to get their screening done. Switching to the eSWIC has made it much more easy for the clinicians to have it scored. We have resources embedded within the electronic health record to send families for that. And then we have mimicked for the older children, for the pediatric symptom checklist and for the PHQ that we have mimicked a Help Me Grow model for those older kids to have some active resource navigation that happens as well.
Thank you so much. So I know the audience can appreciate that there are a lot of challenges in process and those pieces of getting that kind of working upstream to get all of those processes in place, super important, and will vary dramatically according to the setting and where those what screening tools are being applied. And we have a comment from Dr. Paul Dorkin to Kerrie, Schnake, and so Kerrie, we'll follow back up with you. But Dr. Dorkin's comment says, thank you for so clearly and efficiently tying together Help Me Grow's focus on developmental promotion and early detection with advancing infant mental health, as well as the importance of an integrated approach to screening and referral and linkage. So well said. So I agree. And that's something we will circle back around to, of that importance of when screening of making a connection to a supportive resource. So that's a question we'll circle back around to. So thank you, Dr. Dorkin, for that. And then Kerrie, Schnake, maybe you could talk a little bit about, especially with statewide implementation, some of those challenges for a universal screening project, and what are those challenges, and how did you address those of getting a universal screening project up and running?
Yeah, I think it's an important question, and to also distinguish the distinction, I think, between universally available and then reaching families universally, and that's a really important distinction for any of us trying to do any kind of work where we're saying it's statewide or it's universal. Services that are available but not utilized aren't doing anyone any good, of course. So we're working very hard at both of those. And the first is pretty easy. The ASQ and the ASQ social emotional developmental screenings, they are universally available from the Help Me Grow website for any family or professional working with families across the state to complete. So the heavier lift really comes in the second part, and that is making sure that the screening tools is actually utilized. And it can't be done by anyone. It shouldn't be done by any one program. Really, every professional who touches the lives of families and young children, I think, should have a sense of ownership of making sure that families are getting connected to resources, and that includes developmental screening. So that's early care and education providers and home visitors and pediatricians and folks in the child welfare system. It's everybody. So we're at SCIMHA through Help Me Grow and our other programs. We're besides kind of wide dissemination and information sharing, we're doing some very focused community partnerships to serve as champions for infant and early childhood mental health and developmental screenings. And some of those partnerships are initiated with a primary relationship that's built around one of our mental health programs, like infant mental health consultation or our Safe Babies Court program. And then within that's the purpose of the relationship. But within that, we're always embedding promotion of developmental screenings. And then some of our partnerships are initiated with the primary relationship established to specifically promote developmental screening using the Help Me Grow portal and resources. And in fact, right now we have an open application for community partners who serve young children and families to apply for a small grant to serve as ambassadors in their community and promote developmental screenings to families and professionals. So that's really been the approach we've taken to not just that it's available, but that it's being utilized in a way that, eventually we hope through this and all these efforts that we're all doing on this screen and lots of other entities in the state to connect families with screening tools. So hopefully it will be universal soon.
Great, thank you so much. The importance of collaboration on a lot of different levels is important to highlight. So Kristine, can you share a little bit about the work you've done, and especially since you've been in this field for such a long time, with around implementation of universal screening projects and what are those barriers to getting them up and running?
I think I'm just going to piggyback on what Dr. Sease started with it's a process, and you have to really understand that it's a process, but the process it starts, so it can start so many different places, but it's identifying which screen you're going to use for which population, and then having that screen connected with certain specific visits, and then having it, Dr. Sease talked a lot about going electronically, and that's definitely evolving in processes. When we started, people were still figuring out electronic medical records. So it might have been who's going to give the screen to the family to begin with. But if it's order sets, then, how is that going to be loaded for which visit, which screens, and when are they going to be done, as she said. And then that's before the family ever shows up. all those pieces have to be done on the back end. And then when the family shows up, is it done before they get there? Is it done when they get there? If it hasn't been done when they got there, then do they do it then? And then who's going to score it and leave it for the physician to comment on? And then if there's something is identified, then where are the resources? How do you link up with the resources? Both of my colleagues commented that you don't screen just to screen, you screen for a purpose. And if the screen shows that child is typically developing or that family is in a good space, then I'm saying that to the family, this looks great. Your child is exactly where we would hope that they would be. This is amazing. And moving to the next thing, if there is a challenge that's brought up, then that's when Dr. Sease and her colleagues have to kind of use their, how big of a challenge is this? Is it something we're going to monitor? Is it something we're going to refer for? And then how's that referral going to happen? And who's going to get those resources for the families? And that's done community by community, because what you have in Greenville is not what I have in Lexington, which is not what Kerry Schnake has in Charleston. There may be some things, but they're not going to be all the things and accessed the same way. And that leads all the way to what's the family responsible for when they leave, and how is the practice going to get paid for what they've done, or the provider, or the whoever it is that's coordinating those screenings. So I always say that nobody's sitting around a pediatric office waiting for something to do. And most of us that are in social services are not doing that. And so you really have to have a quality improvement science lens so that when you're looking at the process, you're thinking of it as a process, so that when you have to shift, you're still thinking of it as this is a flow of information that's coming through us to help us care for our kids and families, and how do we make sure that that flows smoothly for the clinician, the family, and the other people that are involved too.
And Loretta, I would like to just add really quickly, I learned all that from being part of Q-TIP, right? So the processes and the work that we were able to do, I think pretty successfully here, happened through being part of that collaborative, and then also having been very intimately involved with Help Me Grow before. I mean, all the collaboration happens on a larger scale too, as well as just within your system. So I think we were successful because of knowing Q-TIP and knowing Help Me Grow.
Yeah, again, recognizing how important those collaborative partnerships are, like Dr. Sease and all three of you have said, on so many different levels, but then also recognizing that the challenges, those occur on many different levels, and the importance of stepping back and looking at those processes, but also looking at that QI portion of this work in order to continuously improve the effort. So, and then on to our next question, so which is what the pervasive topic that's kind of threaded through the whole day today is COVID. So as people made progress in implementation of universal screening projects, locally across the state, across the nation, COVID happened. And so one of the questions I'd like to ask the panelists is, how has COVID impacted those universal screening projects that you've been working on? And what efforts have been needed to keep that work going? And are there, I guess we'll start with that, but also to think a second layer to that question is, are there some positive things that may have come out of, or things that we've learned through that process that may, a project may have pivoted differently in order to further universal screening? So Kristine, do you want to start? We'll go back around.
Well, just throw me in the COVID swamp right there. Everything changed and everything stayed the same, because the care that kids needed didn't change. It expanded as COVID hit, and as for a lot of our practices that are doing social determinants of health and also doing postpartum depression screening, like those things were as important, if not more important, during COVID, as people were struggling with just everyday tasks as well. A lot of the processes that were set up within my practices, and this is speaking very globally, this is not, I'm just making a generalization for the purpose of this conversation. A lot of standard screening, is what I'll call it, happens at well child visits. So it's set up in the process so that Dr. Sease mentioned, so between 2 months and 5 years old, they have a specific screener that children get at a specific age. They use the SWIC, but that's also set up that way for a lot of our older children as well. Also, postpartum depression screening practices will usually decide if they're doing a separate developmental screen and a separate postpartum screen and a separate social determinant of health screen. They're going to have specific well child visits that those things are going to happen. And so when COVID hit, some of what happened is, healthcare had to totally shift the way that they do business. And so they had to prioritize who they were going to bring in their office. And so for some of my practices, they prioritized that getting their littlest people seen, our newest to the world people seen, was going to be the most important thing. They needed to bring those children in the office. They needed to lay eyes on them. They needed to touch them. They needed to weigh them. They needed to pinch their little toes and make sure those things that babies can't tell you and that new parents may not be aware of. The Dr. Seases of the world, I always tell people, I had 2 babies. I have an N of 2. Dr. Sease has an N of how many babies has she touched and held and felt, and so they needed to see those small children. And so for some of our school-age children, they weren't getting their well child visits. And so one of the examples when you asked that question that came to mind is one of my practices that traditionally did their depression screening for adolescents. during their well child visits, pivoted to just giving every adolescent a depression screen when they came for any visit. And so that's what I'm talking, that process, has to be in place. They had to pivot, pretty quickly. And so that's one thing that came to mind immediately. A lot of our practices closed their waiting rooms and went to, they became car hops basically. And so then they had to look at the process of, are we doing this on a tablet? Do we need to have tablets that can go out to the cars? And what are the issues with that around cleanliness and sanitation and people touching other people's stuff? And if they're using paper and pencil, then do they, some practices have, a tablet for the parents and a tablet for the adolescent, or a clipboard, or if mom, we had a new mom that I worked with, and she liked doing all her paperwork in the car because the kid was strapped in their car seat, screaming their little head off maybe, but they were strapped in the car seat, not trying to juggle them in the waiting room and do the paperwork as well. So some, like I said, a lot of people shifted to basically virtual waiting rooms. And so I had one practice that had an old garage in the back. So they basically did drive-through visits with the kids, the parents driving underneath the garage, parents, people going out and doing things like that. So I'm sure those of y'all that were actually in the field have more examples of that, but that's what came up in my mind, was just really having to think, if we're not having well child visits, how do we get that same information that's very critical, because we are in the midst of COVID and we might not have asked the 6-year-old's family some of the questions that we would have asked if we'd had a well visit. We don't have that information to go back to. So how do we make this sick visit accommodate some of the needs of a well visit as well?
Dr. Sease, since we're talking about pediatric visits, do you want to follow on, Kristine, and then we'll go to Kerry Schnake? So how has COVID impacted the universal screening projects that you've been a part of, and what efforts have needed to keep that work going?
I would just emphasize most of what Kristine said, right? I mean, we, in the beginning, right, our practices pretty much shut down, honestly. And so having to figure out, we tried to pilot well visits through telehealth, and trying to, just so we could at least lay eyes on some kids and do some of those important developmental screens that we thought were important. That did not work well. It certainly didn't. In other parts of the country, it maybe took off, but it did not take off here. So again, prioritizing those less than 2 to come in, and then those who just needed immunizations for the older kids. So I think everything that Kristine said, times 1,000, right? Trying to figure that out. And then as we learned more about COVID, we were just constantly pivoting, right? Trying to figure out what to do. And then with every surge seemed to bring, some new challenges with that. And then I think we had to really figure out what did we prioritize during the visits when they were there. I mean, mental health, obviously, for everybody, right? For the parent, for the young child, for the teens. I mean, I think that became a huge priority. And then the social determinants, we saw food insecurity rise, fortunately, evictions were being held, but we knew that people were not sometimes in stable housing, people losing their jobs. And so I think a lot of shift. If we weren't doing social determinant screening prior to COVID, I think you saw the necessity to do that, and we all became good at it because it just became this necessity. So I think and I would say we're still pivoting, right? Trying to figure out all those things now. And I do a lot of work in school-based health as well. And again, how I interact with these kids, all my focus is on their mental health, and identifying stable food and housing for them when I do my assessments. So I agree with Kristine. We now try to do, mental health screening every time. We realize that is definitely a priority. So I don't think I think we're, again, continuing to pivot, continuing to figure it out. But it definitely made a huge impact again. And I think prioritization is the key when they're there.
Thank you. Kerry Schnake?
Yeah, COVID hasn't really changed much for the Help Me Grow screening system, since most of the activities happen electronically and over the phone. It did damper the ability to go out and do community events to promote screening. places like county libraries and things. So that put a damper on that. But really it was the referral end of things where the impacts of COVID were felt, because of what we just heard was going on with the places where we would be referring families. There were all the, there was limited availability, there's, long wait list. And so it's really the same impact that you've heard described already. It's just on the referral end for the Help Me Grow system is where we kind of encountered that.
So recognizing how COVID impacted so many life in so many different ways, but really the importance of the information and the importance of screening and the information that's gleaned from them, and then some of those challenges of connecting families to supportive resources when concerns were identified. So one of the big questions around screenings is what happens with the information that's collected on a screening. I think Kerrie, Schnake, you said in the beginning, and everyone's emphasized the importance of screening and then recognizing, interpreting those results and then doing something to connect a family to supportive services if a concern is identified. So what happens with the information that's collected on screenings, and how is that information used to impact individual patient or client or family outcomes, programming efforts, and then maybe impacting community population health? So that's a big question. Kerrie, Schnake, do you want to start?
Sure. I find it most meaningful to just follow the path from the start. So in the Help Me Grow system, a family would go to the website and click a button that says complete an ASQ for your child, and they would fill out the developmental screening. They give consent for that data to be shared with a Help Me Grow care coordinator and their child's healthcare provider. So the data system the license has the HIPAA protections and everything to make that possible. So then the Help Me Grow care coordinator has access to that information. If the screening shows the child is developmentally on track, the care coordinator sends a letter to the family saying, your child's doing great. Here's some fun activities you can do to keep up, this healthy development. If there's an area of kind of question, not enough to say let's refer for services, but like let's make sure you do the next screening in the intervals that are expected. They'll send a letter, perhaps, since they could call or send a letter. They could send a letter that says, let's keep an eye on this. Here's the next time you should do a screening. Here's some activities you can do to really promote development in this particular area. Or they might call the family to gather a little bit more information and decide, is it really kind of a monitoring situation, or would it be best to go ahead and refer for an assessment and services? If the care coordinator is looking at the ASQ results and there is a clear developmental concern, they will call the parent or the family member, gather more information. All that is logged in this system. It's so many data points. And that is then helping the Help Me Grow care coordinator identify what kind of services will be most useful to the family. And through those conversations, it can go beyond just what, like there's a speech concern, perhaps the developmental screening is showing that, but through conversation, these other needs are illuminated that, the parent might have their own needs. And so the care coordinators are trained one of the approaches they're trained in is called FAN, the FAN model, facilitated attuned interactions. And so they're really using this lens of engaging with families in this really sensitive way that allows family members to not just talk about what the screening brought up as a concern, but it opens space where, and the questions that are asked allow other needs to kind of be elevated that might be influencing the developmental concern. So it's this really warm process. And then from all that data, then the care coordinator actually makes the referral in the community, and they're getting down to things like, do you have transportation? What time of day can your appointment be? And they're sorting providers in their resource database who meet the family's needs in these very practical ways. They make the referral, and then there's follow-up to, did you go to this appointment? If you didn't, what was the problem? Can I help you? Can I help you problem solve why you didn't get there? And there was one example, a care coordinator was talking about the mother's had a very unreliable car. It had died, and she said, the car died and I couldn't get there. And she said, okay, let's find a different doctor that's on the bus line, and here's the bus route. And I mean, it's really a very warm, I'm going to help you get to the services you need to get. And so with all of that data, then there's amazing reports that can come out of the system in terms of the needs, in terms of linkages, in terms of where we have in some communities a lot of resources and certain supports for families, and then maybe where there's some gaps. So it's a tremendous amount of information. And trying to think, oh, and the other thing that's important about this system is that once a family is in it, then they're kind of in the loop. So every time their child reaches the next interval, at which point it would make sense to have another developmental screening, they're getting an automated reminder reminder to do the next screening on ASQ and ASQSE. So hopefully that keeps them kind of in the loop and in the habit and practice of screenings for their children through the period of which ASQ covers. I think that answered the gist of your question. I'm sorry if I rambled a little there.
So really important about, and maybe Kristine, you could talk a little bit about it. It did, thank you. And I think that importance of screening, but then also that linkage to service and using that information to follow a child or a client long-term, that long looking at a child over a course of time, and really helping a family access resources, and when they can, addressing those barriers or gaps in care. So super important. Kristine, I wondered if you could talk a little bit about how, when the information is collected, just to reiterate kind of what Kerrie said in across practices or the programming efforts that you do, when the information is collected, how does that lead to services or supports for families? Because I know that can happen in multiple different ways.
I mean, this is probably a question for Dr. Sease, because when the information is collected on the pediatric end, then it's that pediatric provider and their team that kind of assess what they're going to do with that information. So if you're doing a postpartum depression screening with a mom, you're going to look at that score, and it might be that, maybe they're not doing great, but they're not doing horrible either. And the conversation might be around, you're really tired, you've got a brand new baby, this is a lot of work. A lot of moms feel this way. When I see you back in 2 weeks, or we're going to talk about this again, unless, whereas I've had moms who have screened for postpartum depression in the pediatric office and they've ended up in the hospital. So it may be, just they kind of have to go with what moving that mom out to pediatric to mental health services. In some communities, it might be as simple as referring that mom back to their OBGYN. In some situations, moms might not have insurance, and then that office has got to have some kind of resources to figure out where they are going to link that mom back into services. As Kerrie Schnake was describing Help Me Grow, I was over here drooling, because every provider doesn't have access to that, and Help Me Grow doesn't serve every age. And so in some communities, it is I used to have one practice that fully staffed was 4 people. That was the whole entire practice. So, they had to know all of those. They had to have a way to link their families with community services as well. If it's a developmental screen, can I just say one thing about universal screening not being a medical professional? Okay.
Sure.
I give the example of when I had my child, and he went for an OT evaluation, and he was sensitive to fabrics. Well, I've always been really sensitive to fabrics. So to me, it wasn't really a big deal that he only wanted to wear certain types of fabrics. I just bought him those fabrics because I was the same way. It didn't seem to be like a life-changing or life-shifting event. But nurses, doctors, social workers, we're all people too. So we come in with our own set of biases. And so if we have a physician who is used to seeing a lot of children with developmental delays, a typically developing child that may be just mildly delayed might seem to be doing great to that physician based on what they're used to seeing. A child who's an overachiever, a lot of people who end up in medical fields have some little touch of perfectionism, or some touch of like, I want to be at the top of class. I want to be really great at what. Having that conversation with that child might not trigger something for them, because we're all looking at people from our own lenses, no matter how other focused we are, we still come at our work, and that's why we do the work, is we bring ourselves to the work. So I think one thing that developmental screening, universal screening, postpartum screening, I cannot tell you how many times I have had a doctor say to me, I wouldn't have picked this up if I had not screened. And these are amazingly wonderful doctors that I would take my children to and be completely confident that they were getting the best care that South Carolina has to offer for them. But I've had physicians say to me, I just thought that new mom was tired. And then when I looked at her screen, I was like, oh goodness, we got a bigger issue here. Or I really couldn't believe all the families that were triggering on food insecurity, Kristine. Like, I would have never thought that they would have had food insecurity. Or, you know, the kid that walks in and turns out to be suicidal. But if they hadn't asked the question or looked at the screener, they might not have picked it up, because everybody is attending to so many different things in the world all the time. So I just want to say that the screening is a tool for that healthcare provider or that community worker to look at that child or that family in some type of an objective way, so that everybody gets the same questions. We don't pick and choose to only, that's what I was saying, like, when are the screens going to be done? That's a standard process for my practice. They don't. Now, I'm not saying that the doctor always has discretion to bring something else in, but those screeners have a standard protocol for that purpose of making sure that we're not just saying, oh, they're my friend, I know they're fine. Or I've watched that kid grow up, they're playing ball with my kid, I know they're fine. Everybody gets the same thing. So how that rolls out in some of our practices, back to your question with social determinants of health, some of our practices don't have care managers. And so what they have is a vetted sheet of resources that they can give to that family to be able to then go access those resources on their own. Some of the practices may have a nurse that follows up on certain, if screeners are over certain numbers or there's certain issues that pop up. Some of them might have a community service like Help Me Grow that they can reference to, but it's really, that is something that all of the practices felt very strongly about, as they needed to know what resources were available before they started screening, so that they had resources to give to their families in a way that made sense for their practice. So I don't know if that answered your question or not, but that's
it did. Thank you for sharing that. And then Dr. Sease, do you want to follow back up on Kristine's comments and then touch on that the initial question of how do screenings lead to services and supports for the families that you serve?
Sure. Yeah, I think that knowing what your resources are before you start to screen is imperative, right? And again, that so much of that happens in the Q-Tip collaborative, and of course, Help Me Grow has a wonderful database full of those resources. We actually did some postpartum depression screening here very early in a couple of practices we learned quickly the resources were inadequate, and we actually had to stop the screening process because it was unethical, right, to do that. And I think, again, Kristine hit it on the head, right? Like, we have had practices who said, in that one where we started the postpartum depression, they couldn't believe how many positives they were getting, right? Even when we, talked about the national literature, hey, you're probably going to see 10% or more, and they were just surprised, right? Very surprised. And when we introduced the SWIC across our system, which has some social determinant questions in there, particularly some food insecurity questions, a practice that many on the surface would never believe was having as much food insecurity as they were having. And that's one of the early comments we got back from that practice. And I'm looking at Loretta, because before she went to Furman, she worked with me, and this was her big project, is helping me get this off the ground at our health system. So we heard repeatedly from practices, I never would have known. So the idea of doing this universally, whatever protocol you're doing is really important. And again, it gives you an objective measure. So because ours are embedded in the electronic health record, obviously we keep the scores there. Now that we have this eSWIC, and it's a special flow sheet, so we can actually see, what they scored the previous time with the SWIC. There are a lot of false positives intentionally, and so that helps you have that dialogue with the family. So as a clinician, we're making the decision, what do I think? Is this something I can just continue to monitor if it's a developmental concern, or is it something I want to investigate a little bit more? And I will say the SWIC is kind of a drop in the bucket in terms of like a screener for that. All it is a screener, right? We're not diagnosing anything from this. And so we will sometimes refer to Help Me Grow, because we're like, you know what, you think you should have an ASQ, and we want you to have ongoing developmental screens between now and when I see you back. And I know that the care coordination will happen there. Or we have a navigation team within the Bradshaw Institute, where we can have families help kind of navigate into other resources locally here with us as well. And then of course we can go all the way up to referring to developmental peds. And so that we have a protocol, basically depending on the SWIC, how things are answered, we have an algorithm developed for the practitioners to be able to follow. Again, it's a suggestion, they don't have to do it. They certainly can use their own clinical judgment on those. We have an internal database as well for some of the other social determinants resources in terms of how we navigate. Embedded within the medical record is those vetted resource sheets that Kristine mentioned earlier. So we have them broken down by the patient zip code. Whatever is entered into the demographics into the EMR will automatically populate then on that patient's AVS, or the after visit summary. So again, you're taking into account, how concerned am I? Here's just a list of resources if the family wants to follow up on their own, or here's some resources I'm circling saying, hey, I really want you to call, versus I'm actually going to refer you to our internal navigation team who is going to help you navigate this. We have community health workers as well who can help families, particularly in our patients who prefer to speak Spanish. Our PASA's organization can help connect them, can actually help them fill out paperwork. We can address those social determinants. So it's a little bit different here. I realize as I'm saying it, how privileged I am to practice like this, because I have so many resources at my fingertips. But it takes that kind of process to be able, I think, to accurately navigate. There's some good literature out there about passive versus the active navigation. And certainly I think with more of these social determinants popping up in some of these vulnerable populations, that active navigation is really important and helps them actually get to the service. And then I think, Laura, to your question about how does it inform some of our community health and work that we do within Prisma Health, we can download information from our electronic health record. We also keep a REDCap database where we capture a lot of the social determinants work in there. And so we can look at what disparities are we seeing, which practices aren't referring as many as the others. Are we seeing differences in people who prefer to speak Spanish versus those are English? What are the waiting lists for resources in our community? On and on and on. So we try to take deep dives into that data. Again, very privileged, work with a great research team from Clemson who helps identify some of those for us. And then we try to give that information back to our community, back to Prisma Health. We're trying hard to integrate it closely within our community health needs assessment. So we are looking as a large health system, we feel like we have a responsibility to help drive some of the community health efforts that happen based on the data that we're collecting.
Thank you all. I mean, that's so comprehensive between the three of you to really describe the importance of universal screening, and then when concerns are identified, how to address those. And like Dr. Sease summed it up, not only impacting an individual, their family, but then really looking at kind of at, community health and programming efforts that can be made to address community health needs. So well said. We have a couple questions in the chat or things that I need to highlight, and then we'll circle back with some kind of questions to tie up our wonderful session, and the information we've learned has just been phenomenal. So thank you. One, I want to start, Jane Watowski from Help Me Grow said, just for clarification, all primary care practitioners can use Help Me Grow for screening and linkage to services for their patients birth through 5 years old. So more information on that, you can reach out to Help Me Grow. They have a wonderful website, or Kerry, Schnake to follow back up with. But that good clarification and information from Jane Watowski for Help Me Grow. And then Tyson Tyson Barker has a good question that we have not yet addressed, but super quickly, if the panelists could address, could you describe how you compare the pros and cons of different screening tools? And that's a really big question, because there are, I think all of the panelists has referenced, there are a lot of different screening tools out there. And that is, what was your process and factors that were considered for selecting specific tools? So I know that's a really big question, but would somebody like to address that? I guess maybe Kristine or Dr. Sease, since you guys are you utilize different, various different screening tools at different ages and to address different concerns.
I'll jump in, and that'll be great for Dr. Sease to piggyback because her practice has moved through some different screeners in the time that we've been working together. Honestly, Tyson, I just saw your presentation. In 2011, when I started researching screening tools, there were 3 criteria that I looked at. One was, and we're a quality improvement project, we're not a research project. So the criteria were, what is free domain, because we were a grant at the time and we wanted tools that our practices would be able to continue to use if there was not reimbursement attached with them. So what was free domain, what surfaced over and over again in the literature. And then for my practitioners who are already screening for that item, the docs that I already had in South Carolina that were screening for whether it was development, postpartum depression, mental health, what were they using and why did they choose it? And so that's what kind of bubbled up to the top of our recommendation screening protocol. But as I go around the state now, I went just to jump, Prisma actually started off with a different developmental screening tool because the SWIC was in the process of being developed and being vetted at the time that we were recommending our screening protocol. So and now there's a lot of literature about different screening tools and different ways to use them. And so that was our original recommendation. And then as Dr. Sease said, our practices learn from each other. And so if I have a physician who asks me, what about this or what about that? Then I will put them in touch with another practice that's using those screening tools to say what they do or don't like about them so that they can use their clinical judgment to talk about what they like or don't like. And then for my practices, I also keep the mental health toolkit screening tools as a PDF that I add comments to. So I will add comments about what other practices are using those tools, pros and cons of what I've heard those other practices say. So if one of my Q-tip practitioners was like, I'm looking at this screening tool, I would send them that AAP document now and say, here's, look on these pages for these types of tools or things like that. So it's very much suggestions on my end, but the decision making happens at the practice end based on where they feel like their patients' needs and strengths are.
Yeah, and I'm happy to follow up on that. So, we started here with the PEDS questionnaires, which are at different intervals. Not at every well child check like we do now, but we followed the AAP's recommendations. So that I would say that's probably for the majority of what we do. And again, since the Q-tip collaborative is part of the South Carolina AAP, we clearly look to the AAP for guidance on that. And that has evolved over time in the last, 10 or 11 years in terms of what has been recommended, what is allowed to bill for, et cetera, what's in free domain. And then we worked closely, as I mentioned earlier, with our developmental PEDS. So we started with the PEDS questionnaire, then we added the Edinburgh postpartum depression, we did MCHAT, and then the PHQ came on. That was a system initiative for us in terms of the depression screening for the adolescents. And then we're adding the pediatric symptom checklist now for that 6 to 11-year-old. And that was done again in concert with child psychiatry and developmental PEDS. So looking at what bright futures, as recommended by AAP, what's in the literature. And then also an important part for us when we did switch to the SWIC was there was a lot of screening burnout, right? And a lot of screening fatigue. And this was when it was all paper. Our front office, had to determine what age well child check gets what do we do here? And so we're like, what can we do to simplify the process, but still get what we thought was going to be important information for us to make decisions. And again, we don't think we chose, the absolute best in the field, but we also feel like it was something that was going to give us a comprehensive look at the family and was going to be something that we could have consistently done within our practice. And I will say when we switched from multiple screeners to one, our compliance rate went up significantly. And as we did this across our health system, and again, Loretta gets a lot of credit for this, as we then help support our other practices to do that, by trying it in a few practices first and figuring out the kinks and what we were doing, when we were able to spread this across our system, again, the compliance rate is unbelievable in terms of our practices, giving the screening, documenting it appropriately, because it has to be scored and documented in the electronic medical record. And then for those practices that can bill for it, to have the billing done correctly as well. So that, again, a lot of it was what is going to be the easiest for us to do. And then for us, making sure that our child and adolescent psychiatrists and developmental pediatricians were okay with the screen. And we worked with them closely on the algorithms too. What do we do when there's a positive? What do we do next? So that we weren't just knee-jerk referring either to psychiatry or developmental peds, but there are some processes in between as well.
Thank you both. So lots of information. I know it's a lot of details, and there are complexities to the tool that's selected and the process and how it's implemented and outcomes and how families are connected. So this has just been a wealth of information from the panelists. We're super appreciative, and we're getting close to running out of time. But we do have one comment, which might be a good place to kind of close. And then we've scheduled, this is the last session, so hang in there with us for just a sec. Anita's comment, I think, is super important. We know there have been an increase in screenings done, especially in the area around mental health, and wonder how much that screening may be contributing to the fact that we're seeing a rise in mental health symptoms of anxiety, depression, and suicidality. And so Dr. Sease, would you like to address that? We've talked, I know that's been a topic that's gone throughout the day, that's not something I can say to address briefly, but there is significance to that in the increased number of screenings, but also in the increase in mental health. And Dr. Sease can address that specifically.
Sure. Yeah. I mean, I think anytime you screen more, you're going to find more, right? Because we're actually asking. So I think that is true. I would, and not to assume I know exactly what you're saying there, but obviously, I mean, there's obviously a mental health crisis as well. And so I think the idea for adolescents particularly is screening every time you see them, right now, is, I think, the right thing to do. So a lot of us initiated that in COVID. Again, I told you I do some school-based health work. We universally screen everybody who walks into the school-based health center, even if you're coming in with a stomach ache or you stubbed your toe. We're screening everybody because the rates are so high. And so, yeah, I think we are seeing more, but there's absolutely a crisis going on now. So I think we need to be screening more.
And I think one of the things too, to piggyback on what Dr. Sease said, is the importance of universal screening and kind of maybe identifying some of those concerns upstream, and that you've kind of heard that theme through all of the presenters of screening universally and identifying those concerns, and then helping families, connect their children to those supportive resources in the community. So I have 3 or 4 more questions, but I know we're out of time. This has just been phenomenal, and we cannot begin to thank our panelists enough for sharing their expertise and their knowledge around screening and universal screening, and really being that key component to well-being for children and families that we all serve. And I think if we go back to what everyone's highlighted, we all serve collaboratively. So super important. This work is just amazing. And we're thankful for the partners across the state who are doing this work, and then partnering together to make sure the needs of children and families are getting met. So we've got one more. Is a child being in foster care considered to be a high risk for universal developmental screening purposes? Kerry, Schnake, do you want to answer that really quickly? That's not really quickly, but
yeah, well, I think I can just say that the protocol for the child welfare system is that if there is a child involved in the child welfare system, their developmental screening should be happening, part of the normal, the array of things that a child gets when they come into the child welfare system, and developmental screening is among those. I'm not sure if that.
Super important component. And then I've got a few housekeeping things, and then we'll wrap up. Let me say thank you to our presenters and to our audience, and just thank you for the great work that everybody does across the state. Once again, if you're claiming credit for SC endeavors, please make sure that you complete the Google form at the top of the chat. And I think Mark has just added it once again for everyone to access. We will be providing a recording of this session to all attendees versus email in the coming days, so look for that. And then just thank thank you once again to our presenters. Just so well done. And thank you for the incredible, phenomenal work that you do every day. And thank you to our audience for the great work that you do and for engaging with us in this conversation. We hope everyone has a wonderful day. Thanks for hanging in there with us for the last session. Happy Friday. And we'll hang out for a minute or two more if you need anything, but thank you once again.
I was going to just piggyback on, if anybody's still on Dr. Sease's comment, I get to see the numbers from across the state for our Q-tip practices. And what's phenomenal to me is that often, if not all the time, our Q-tip numbers, prevalences for positive screens run right along the lines of the national norms. So exactly what Dr. Sease said, if you're going to have, one out of, if you know the statistic is going to be 1 out of 5 kids nationally are struggling with depression, often our Q-tip numbers are right in line with that. I mean, we're not off by, we might be off by a few percentage points, but those numbers are really, do you find that too, Kerry, with your stuff? Yeah, those national numbers really do, we do run in line a lot with those national, with children that are being identified with autism or developmental delays or mental health. It's often those same percentages we're going to find too.
Yeah, and I can say, before we instituted some of our universal screening the way we're doing now, we were probably below some of those numbers. And so just the reason we do it, right, is so that we can identify those. And early intervention, we know, is so incredibly important, and particularly in the developmental space. But for the mental health numbers are staggering, right? But most kids don't get the services that they need, or if they do, they're in a crisis, or so we know that early therapy for that is going to be important as well.